So Ruth, tell me a little bit about what your current position is, where you're located and all.
Sure. So I'm a health psychologist by training, and currently I'm the director of research at Duke Integrative Medicine in Durham, North Carolina. And I divide my time between clinical work, which is where I get my real juice, and research and some administrative work as well.
Okay. And the focus of your current research is
on the use of integrative treatment approaches for many different things. We have different studies, and health coaching is kind of the frame which holds whatever the integrative approach is. So, for example, we have a trial going on right now with severe tinnitus, so people that have a ringing in the ears that is so distracting to them that they're not able to function. And we're looking at the use of either sound-based educational approaches, which is sort of standard of care, or that plus an integrative approach where the coach, an integrative health coach, actually holds the 6-month process for the patient. And in that, across that, the patient learns mindfulness meditation, and they also do some cognitive behavioral therapy work, and they get some acupuncture. And the coach helps them to integrate all of it and apply what they're learning to their individual lives. A second trial that we're doing is basically using health coaching to help people that are at elevated risk for cardiovascular disease and people that are at elevated risk for diabetes to be able to shift their behavior. And this particular trial is a combination of the use of genetic information with this approach to helping people change their behavior.
Okay, good. You used a term that, if I can, I'd like to get a definition of.
Sure.
You said integrative health coach.
Yes.
Can you talk about that a little bit and give us an idea of what you mean?
Sure. So an integrative health coach, this is the term that we've been using the term integrative health coach for about 7 years now. It's a person who has gone through the training program that Duke has in health coaching, but it is broader than typical health coaching training in that it has mindfulness meditation as a very important way in which to help people increase their self-awareness and increase their presencing to be truly with clients. It approaches health and wellness in a very holistic perspective, and it often draws on therapeutic modalities that are wider than those offered in conventional medicine.
Okay. And who would be, or what would the backgrounds be of people who come into your training to be integrative health coaches?
Well, so to enter the training program itself is a 113-hour foundational training program, and then after that they go on to a certification program. What we found is that we can get a lot of sort of information and description of techniques across in the foundational program and some level of practice, but it's not until people have actually sort of in the real world been doing the kinds of processes and interpersonal techniques that they really have the skills to a place where we would feel comfortable saying, yes, this is an integrative health coach. So they then go through the certification program, which involves a lot of coaching and mentored coaching and supervision on their work, listening to tapes of their sessions and so forth. So people that come into the program at this point have to either have a bachelor's in some kind of healthcare field, allied healthcare, and a certain amount of training experience. So for example, the field of nursing converted, and at one point you didn't have to have a bachelor's degree, but there's some fabulous nurses, right, that don't officially have a bachelor's degree but have a myriad of experience that would qualify them. So there are some exceptions to the bachelor's degree component.
Do you get a lot of nurses coming into the program?
We get nurses, we get physicians, we get a lot of people from the field of mental health, social workers, psychologists, registered dietitians, exercise physiologists. We have a fighter pilot, we have firemen, we have a number of people in health promotion. I mean, it's really a fascinating group of people because they come from such diverse backgrounds.
Good. And wellness coaching is a relatively new, or health coaching. I think they're interchangeable terms, or not?
So that's a very useful question as well. I think of wellness coaching as helping someone whose health is already pretty good improve their health. And I think of health coaching as the person has, the coach has more of a background in sort of the medical world and how to navigate it and at what point people need referring elsewhere. So I think of more knowledge and experience with the so-called health coaches, specifically experience in the medical field. But I will tell you that nationally, these terms are used with no standardization whatsoever. So it doesn't mean that you have to have any kind of a degree at all. Anyone can call themselves a coach, and anyone can call themselves a health coach or a wellness coach. And there's actually a big discussion going on, of course, at a national level about what should the standards be for this.
Right. Well, and it's something that's being discussed in all fields of coaching and around. So I know that a big part of the presentation that you're going to do for the conference today has to do with an obesity study, which I know nothing about. So can you give me the short course on that?
So I can, and Jerry Jerome is one of the authors on that study, and he actually oversaw the coaches and helped to develop the paradigm they used. So he's closer to the source.
Yeah, I think what I'm interested in from you, Ruth, is how that study fits with the work that you're doing at Duke, and where the intersection is, because I want to go from there forward into where you see this field going.
Oh, okay. All right. So this study that came out in the New England Journal of Medicine, really basically took the paradigm of coaching and added to it a lot that we know from a behavioral science perspective. And as I said, Dr. Jerome can give you more details. But basically, what we're learning about, the last 20, 25 years in the field of behavioral science, behavioral medicine specifically, we've learned a lot about how to help people change their behavior, and we're really clear about how much we don't know. So if you think from a kind of statistical model that's very common in conventional research, you try to explain the variability of outcomes based on aspects of the intervention. And the strongest behavioral science still only explains about 30%, 31% of the variance. Actually doing research in this field is really complicated for multiple reasons. And I'm going to try to, so I want to explain why that is, and I hope this isn't too
No, it's great. It's great. Okay. No, it's exactly.
Okay. So in conventional medicine, there's a very specific research paradigm that has evolved over decades and decades. What an intervention has to do to demonstrate that it works and get out, be disseminated for the public, first it has to establish safety. Then it has to establish efficacy, which is basically that the mechanism of action is understood and it works. So it's based on this principle called analysis and isolation, where everything in an experiment is as controlled as possible so that you know for sure that A caused B. So if a drug company wants to put out a new medication, for example, you want to make sure that it's not the belief that the medication is going to help you, that actually changes the outcome. Very strong research exists on the power of belief to change biology. So you want to have a placebo control where people are randomized into either condition, that gets the active medication or that gets the placebo, so that the sort of power of expecting to get better is, equalized or controlled for. And there's just myriad factors that need controlling for. So in biomedicine, what you're doing is you're trying to take away all the noise, if you will. You're trying to control all the extraneous variants, so you know for sure that this little piece of the intervention is what worked to cause this outcome. And then once that's established, you move to effectiveness research, where what was done in the laboratory or what was done in an incredibly tightly controlled trial then moves into more of a clinical practice where there's a lot of different variables. So in the clinical trial, for example, they might have only used it, let's say we were creating a medication for to, help psoriasis. We'd want to make sure that the patients in the early trial, you want to control so that the patients are as homogeneous as possible, so that it's clear where the differences are. But think about it like a big football field. And if your task is to identify among hundreds of dogs that are running around on the football field, which dog has a red collar. If they're all sizes and shapes and colors and have all different collars on, very hard to find where the heck the red dog is, but the red collar is. But if all the dogs are black, middle-sized dogs, it's homogeneous, you can find the thing that's different most easily. So what we want to find, what typically happens in biomedicine is you get the group as homogeneous as possible. So you only have people that have psoriasis and they have no other conditions, and you have them in a pretty tight age range, Well, then when you move it to effectiveness research where you have less control, then you start in the primary care practice, this person has psoriasis and they also have, heart disease, and they also have whatever else. And we want to know, does it work in 65-year-olds as well as does it work in 22-year-olds? And so you start having a lot more variability. So safety, then efficacy, and then effectiveness. That's the biomedical model. What happens in coaching is that we're trying to demonstrate that an intervention works in the field of healthcare, and healthcare has, the biomedical model is the strong model, so we have to establish credibility using traditional methods. But it actually makes no sense whatsoever to do efficacy trials at this stage for coaching, because you can't control out a lot of the factors in coaching, right? If an individual beliefs and preferences, their own goals, their own agenda, there's so much about an individual that you can't sort of randomize away or hold steady across multiple conditions. These contextual factors that get controlled in traditional biomedical efficacy trials, they can't be controlled. So as we're looking at, does coaching work, in healthcare, what we're actually asking is more of an effectiveness question. So we're looking at a full intervention. We're not looking at a particular piece where we can say, we know from an empirical perspective that this is the reason that happened. We know it's this particular thing the coach did or said, et cetera. So in coaching, of course, you have to have safety, which is another reason we need really good credentialing and standardizations. But you go effectiveness first, and maybe efficacy at some point. I mean, I personally would even argue that it doesn't make sense, but we're trying to find a middle line to be accepted by the traditional biomedical model in terms of understanding and getting the studies in peer-reviewed literature, getting funding for this from NIH and other large funders.
So you really do have to create a new model of research in order to do this, because the fact situation does not lend itself to the biomedical model.
That's right.
Okay. Can you tell me a little bit about what the coaching would actually look like in one of these studies?
Sure. So they've all been slightly different in terms of the overall intervention protocol. The standard is it's a one-on-one coaching intervention. So let me back up. So we've had about 7 studies that we've done. And the interventions range from only coaching, pure coaching, to coaching plus some kind of an educational intervention as well. So, we know that education is important, it's just not sufficient. And the way that coaches provide education is different than the way that most advisors, particularly in the field of healthcare, provide information. So it's not a advice lecture, let me tell you what to do, but it's more a kind of inquisitive discovery, pulling from the client and letting the client lead. But so in our first proof of concept study, we had group-based education that was led by the coach. And so the group were taught certain skills like mindfulness meditation, how to, on the internet, discern whether something was a credible source or not, if you want to get more information about some aspect of your health, how to build social support. So we had a lot of skill building in a group setting. And then we had one-on-one telephonic coaching bi-weekly for 10 months. In another study, we had only the telephonic coaching, and we had a notebook that we had compiled with solid information. In that the particular study I'm referencing now was with folks that had type 2 diabetes. So if a participant had a specific question, we wanted to make sure we were disseminating standardized information. So they had some information, but the intervention itself was coaching, telephonic coaching. The initial session is always a little longer. We call it self-discovery session, where the individual begins to explore for themselves what they really want, why making health-related behavior changes is important to them, and then individual telephonic sessions. In another study, we did group-based coaching. And so we had the coach leading a 6 to 9 person group. So those are the basic venues, and then they may have some of the studies have more education, some of them have more group work, as well as individual coaching.
Good. Where do you think the frontiers are on this? What do you think is going to happen next?
Right. So I think in order to move research forward, we absolutely have to standardize the definition of coach. Specifically within the field of healthcare, whether it's a wellness coach or a health coach or a health and wellness coach, absolutely have to standardize the definition and have some kind of credential that clarifies. Because if not, we are comparing apples to oranges. There are over 200 randomized control studies that reference health coaching. The vast majority of them are doing things that I wouldn't call coaching. But it's a term it's cool, and people like to use it, and it sounds so patient-centered, which is cool right now. So,
okay, that actually gives me another question.
Mm-hmm.
How would you define coaching, health coaching?
So it is a process, a patient-centered process where an individual with specific training helps a patient in the medical model, client otherwise, helps them define for themselves what they want in terms of their health and set goals. And then more importantly than actually setting the goals is giving some support and structure to a learning paradigm within which the individual patient or client can try new things to change behavior that can be truly sustainable over time. The coach, in sort of holding this learning paradigm, is in the position of making it safe for the person to expand and kind of stretch to try new ways of being. contrast that to, say, traditional health education, where an educator might tell you, here's what you need to do. But, we all know lots of things we should do and we don't do them. So that gap between what we should do and what we're actually doing is filled with lots of things like competing commitments. Sometimes it's lack of knowledge, but usually not. What an individual's real motivation and passion is, and what I think the biggest job of the health coaches is helping patients link healthy behaviors to their specific personal goals. So, for example, in our proof of concept study, patients just did amazing things. It was fascinating. They dropped their medication, they lost incredible amounts of weight, they brought their blood pressure down, so on and so forth. And we had gathered people together for some interviews, and the medical folk were all thinking, wow, they went off their cholesterol meds and they lost 62 pounds and they whatever. And the interviewer starts asking people, how did you know when you were successful? And the first guy says, oh, because I took my wife dancing for the first time in 25 years. Right? Oh, because I've got my boyfriend eating vegetables now. So they were things that were about the individual's lives. They were not about the medical parameters. But the medical model, the insurance systems, the whole way the whole thing works is all based on symptom reduction. So as we move this kind of new model in, there's an interesting process between how much the health coach needs to understand about the current medical model and how much they can truly support an individual to do their own self-discovery, their own learning about behavior change and what will stick for them. Since they're the best experts on their own life, they may not be the best experts on what the science says or, right, but they are clearly the person that's going to either sustain the behavior or not. And so truly listening to them and helping them listen to themselves.
Well, and it is similar to coaching in any of a number of other fields, where what you're doing is, I think, flipping the traditional relationships so that it becomes patient-centric, client-centric, rather than coach-centric or interventionist.
Right, and I think the biggest risk, or one big risk, is that because the medical model is so steeped in, I know what you need to do, here's the behavior change that is needed, because it is so steeped in that, it's really hard for people to shift and allow patients to really be their own experts at their own behavior change, at seeing what works and what doesn't work for them. And it also has to do with, responsibility. Physicians are trained to be responsible for everything and sued if they make a mistake, right? So that's a whole other...
the other shift is shift the accountability
yes.
to the client, to the patient.
Yes.
Instead of holding it for them.
That's right.
Cool.
Yeah.
Thank you very much.
Absolutely.